That is cool. So this is the palliative care room. So this means that this is the death room. My goal is to say one day this room doesn't exist, right? If you're going to say, if you're a cancer doctor, and we do have a very good and empathetic and sympathetic program that helps families with death and dying, but it's a failure, right? It's all very well to say, well, we all die, but it's not okay when kids die. Not in my mind. Kids shouldn't die of cancer in the richest country in the world. We should have the right research. We need to make the right advances. So that's why, to me, this is like one day when I can turn this into a good pool room and we can have parties in it. We've won, man.
At the crossroads of passion and dedication, you will find a pediatric oncologist by the name of Dr. Leonard Sender. His commitment to specialized care in the field of adolescents and young adults was a building block to the trend of personalized care that we see today. He is also the constant example of a doctor willing to go above and far beyond for his patients.
The adolescent young adult has this uniqueness about them. It's such an amazing time in your life. You're drawing away from your parents, you're becoming independent, you're still doing fun things, you're going with your friends, you're exploring your world, you're exploring your sexuality, your choices. To suddenly have cancer at that age is devastating because you don't have the roots yet. There was an abstract done in 2000 by Wendy Stark at the American Society of Hematology meeting, and she looked at the difference between 16 and 21-year-olds going to a peds place versus an adult place, meaning they got put on a clinical trial at one or the other, and said, what are the outcomes? And the outcomes were about 70% survival versus 40% survival. That was the first inkling, oh my God, there's a difference. Well, then the question, well, is it because they're bad doctors? Of course they're not bad doctors. Is it because the hospital's bad? No, it's not a bad hospital. It's treatment. So what we're learning is, yes, we can correct easily delivery of care. Give the best treatment we know to patients, regardless if they're in a peds hospital or adult hospital. The second was, let's really take the time to learn about the biology. Let's take the time to say, what are the underlying realities of that leukemia? Is leukemia all the same? Or are there differences in different age groups? Does someone who's 60 years of age have a different type of leukemia to a 40-year-old, to a 25-year-old, to a 10-year-old, to a 3-year-old? And we can answer the question, it's going to be yes. We need to acknowledge that the patient is as much a part of our research. They are researchers themselves. So when a patient goes home and you say, has anyone in your family had cancer? And they say, I don't know. Let me go home. They call their uncle and their cousin and their brother and their sister and they say, well, that's researching, right? When they go to Dr. Google and looking up stuff and bringing you information, they're acting as patient researchers. When you ask them to fill out a diary of side effects, they're collecting data. They're data analysts for you. We need to acknowledge that this is the only way we're going to do this is when we fully engage the patient as a patient researcher, where we all say, I am a cancer researcher, regardless of what component. It's not anymore this professorial look down, oh, I'm the only one who knows what's good for you. If patients don't join our studies, if they don't give us their tissue, if they don't give us their contextual data, if they don't participate in the clinical trials, then we're not doing research. We together can find a cure for cancer, and it's really going to take a we, not an I, and that's what it should be. The sad part is our country is taking away the money. We've done great work, but with the government cutting down the amount of money they fund into the National Cancer Institute, by not increasing, not even keeping up with inflation, but going below, the fact that we have less money than we had 10 years ago is a terrible mistake. One is we're ruining great young scientists who started their career. The second is that will have a downstream effect. We will also stifle innovation because there's no money. When you take a grant and take so hard to get a grant, people are not going to be excited and innovative on the grant. They're going to turn around and do the safest thing possible. We need people to be bold. Right. Peter Diamandis, and from X Prize, in his book Bold, talks about, they've got the companies out there that decided to go and mine asteroids. Isn't it the coolest thing in the world? Think about someone who's thinking about a world that says, let's go mine asteroids. They don't go and say, let's just look at it. They say, let's go mine them. We need that type of bold thinking, innovative thinking to change cancer. We need to think of a world that's not the same as the one we got now. We made those great advances since 1947, 48 when Sidney Farber was there. But look at the consequences of the cure. We've got a lot of people cured. We've done a lot of potential harm. So what we've got to do is we've got to learn. We're not done. So when people say to me, well, you're curing 80% of pediatric leukemia, or you're curing 90%. First of all, they mistake the data because they say it's not all leukemia. There are different types of leukemia. So one is we're learning the different types.
Right.
Some we're learning we have got 97%, and woohoo, it's fantastic. And we're reducing the therapy. Some are only at 60%, some are even lower. And we have it sometimes with I call the consequences of cure. Chronic illness, second malignancy, heart disease, infertility, transplantation-related mortality and morbidity. So our goal right now is to say, regardless of what everyone says, well, we're doing great, why are you asking for money? Why do you need Leukemia Lymphoma Society? Why should people donate? It's because we're not done.
In an effort to show us why his work will not be done anytime soon, Sender introduces us to one of his recently diagnosed patients, teenager Dalvin Barnes.
You got a unique cancer, very rare cancer. We don't know a lot about it. The only way we're going to know about it is to do research, right? Is to get tissue and to understand it, to sequence, and that's what we're doing.
What type of cancer do you have?
I'm not sure if I say the first part right, but it's hepatosplenic T-cell lymphoma.
Yeah, so he has something called gamma delta hepatosplenic lymphoma. So hepato means it's part in the liver, part in the spleen. It's a lymphoma, which means it comes from the lymph nodes or from the type of cells, and these are T cells. Yeah. And then he's got a particular type, which is called gamma delta. Most of them are alpha beta. So he's got he's a rare bird, man. You knew he was 1 in a million, but you didn't realize how rare he really was.
I was diagnosed February 24th, that Friday. I'll say February 26th or 7th. That's when I officially found out that I was diagnosed with the lymphoma, because they took out my spleen. I had a splenectomy, and then once they did the biopsy, that's how they found out that I had the cancer cells.
You were diagnosed when you were applying to go into the Navy, right?
Yes. So all January I was studying for the ASVAB, trying to go into the Navy, and then February 10th was my test to go into the Navy. And then, but a week before that, I went and got my physical done, and I had these blood clots in my mouth. So I told my primary. He told me to go to the doctor to get it checked out immediately. So I went and got it checked out to make sure my blood was clotting. February 9th, that Monday, I got my results back, and that's when he told me my platelets were low, my hemoglobin was low, and my white blood cells were low. So I had to go to the hospital immediately. And after that, been doing all this ever since. I had a few friends visit so far. Then of course, my mom, she works, so she can't be here every day, but she comes on weekends and times when she can. Yeah.
Very good, man. While the majority of 17-year-olds will spend their time overthinking non-critical matters, Dalvin, a small group in the same situation, are being subjected to the weight of a matter far greater than what should be expected. In spite of the dense burden, Dalvin remains poised and positive for the ensuing battle.